So I'm Adelina Comas-Herrera from the London School of Economics, from the Care Policy and Evaluation Center, and a member of the International Long-Term Care Policy Network, where we set up this thing called LTC COVID. And today is our first public webinar. We're very excited to be doing this. It's a very serious topic, so it's very timely to have international learning on what's happened in terms of COVID in the long-term care sector, and today we'll be focusing particularly in care homes. This is the first of a series of webinars. We will be announcing some of the next ones in the future. We're looking for speakers, so have a look. If you think this is good and you have something you'd like to contribute, you're very welcome. Please drop me an email and let me know if you'd like to speak. So I'm very, very pleased today to introduce, first of all, I'm going to mention the other speakers. So we've got, I can't remember the exact order you're going to be speaking in, but I'll stick to what's in the program and I might need to have a look. But we've got Courtney van Hoven going to speak from the US experience. We've got Claire Goodman, we've got Li Fei, and we've got Peter Lloyd-Sherlock, who's going to be presenting. And first of all, I'll give you a very quick introduction of what's LTC COVID, and also some of you may be new to it, and if you'd like to get involved, please do. So I'll go very quickly so I don't eat into the time of my co-presenters, and I'll be sharing with you. Right, so that's, I think that should work. Be great if somebody could tell me if you can see the slides, just so I know that this is working.
Yes.
Yes, fantastic, thank you. And let me minimize that so I can see. So just to introduce you, LTC COVID, this is our first webinar, and what LTC COVID aims to do is to document the impact of COVID-19 on people who rely on long-term care, including unpaid care, and those who provide it. And the idea is to share information about policy and practice measures to mitigate the impact of COVID-19, and to gather evidence about the success of these measures or otherwise. And we hope that we'll be able to analyze the long-term implications of this pandemic for long-term care policy. So what is this? So LTC COVID is actually a spontaneous collaboration. It happened in a very, as a quick response to what was happening as a blog. And we were trying to, when we started, really the only information we had was coming through newspapers in different countries, and some early examples of LTC COVID, especially affecting really badly some care homes in Spain and Italy. So we started to try to document it, and we were able to build on the International Long-Term Care Policy Network, which is basically where LTC COVID is now hosted. And this is based at the London School of Economics, but it's an international network of researchers on long-term care and also policymakers. And we have usually a regular conference every 2 years. Our next one is due in January. And we were able to build on this international set of experts who were also concerned, and we all wanted to share learning. So we all sort of came together, and LSE through ILP and CPEC has been funding so far the website and some research assistance. We are looking for some further funding, so any ideas are welcome, and to be able to provide more support in terms of analytical contents and perhaps help sustain some of the effort. This is now evolving more from a documenting site to more of a policy and research resource. And I also want to mention that there's a link between ILPN and the Journal of Long-Term Care, and we expect that some of the resources that are and reports that are currently published in LTC COVID will be then becoming articles in the Journal of Long-Term Care. So far, we've had over 90,000 visits to the website as of today, visits from over 156 countries. A lot of the visits have come from the UK, but also from the US, Canada, and then some of the countries that were the early contributors. And but we see the number of countries visiting the website grow, and I think that there'll be also increasingly attention to this from low and middle income countries as well. And we know that we'll have some more reports coming from those countries. So you can see we've had visits from a lot of countries in the world, and it's very impressive. And we hope obviously to make sure that the content is increasingly helpful to different parts of the world with different resource settings. The current website has 4 sections, one on country reports, one on international reports, then there's a growing emergence evidence section and a blog. The country reports all follow a similar outline. So they have a more general where we're at in terms of impact in each country, the impact on care users and staff, a bit of background on the long-term care system, and then we try to collect information on the long-term care policy and practice measures. And then there's a reflective section on lessons learned so far, the more short-term calls for action and longer-term implications. And if anybody, well, I'll mention that in a minute, we have reports for quite a few countries. There's a few countries where we have somebody who has started or has offered to prepare a report, and we'll be welcoming, of course, offers from other countries. Also, in almost all countries, I think I can say that the authors would be very happy for additional people to join, because these reports are not frozen in time, quite the opposite. They're live reports. The idea is that they keep being updated as new developments happen, new evidence emerges, and new lessons can be learned. In terms of international thematic reports, at the moment we've published 3 so far. One on care home mortality that's attracted a lot of headlines and hopefully has helped to provide a bit more, make sure that this issue is more widely recognized. We've got one on end-of-life provision of care in care homes, and one on measures to prevent and manage outbreaks in care homes. And we've got some under preparation. There's the two first ones, measures to maintain community-based care and protect users and staff, and one on unpaid carers that are almost ready for publication. And then we've got under preparation one on people living with dementia, one on people with intellectual disabilities. These are the ones that we've started on. And we're also developing other parts of the website. One is the evidence mapping and summaries. So we're registering today a live systematic review to search for evidence on the impact of COVID on people who use and provide long-term care. And we also will be looking at any evidence on how the measures have worked, because at the moment, most of what we have is very anecdotal. We're planning to track the evolution of the evidence base. So we've started, as I said, with newspapers report, some epidemiological impact studies, some analysis of statistical offices data, to hopefully there'll be soon evaluations of measures or interventions. And we will aim to produce jargon-free research summaries. This is all subject to research funding that we hope will be in place, but that's the plan. And we're also working with the name is in Spanish, but a Center of Documentation Studies Center in developing a searchable resource database, and that we expect to come to the website soon. We have had some discussions with contributors so far to the website. We will be continuing that, but there are some other themes that we could explore in international reports. For example, the role of information systems, issues on financing, both in the short term to deal with COVID specifically and the additional costs, but also the implications of the way we finance long-term care for how we have been able to respond to COVID and what would need to happen in the future. An issue of boundaries between different government departments and different levels of government, the physical fabric of care homes, as some people thinking about the report on that, issues of workforce, of course, from pay and conditions to immigration policies. And then there's the market characteristics of the care home sector. So these are some themes that have been identified. There are a few more that I understand some contributors to COVID, LTC COVID are thinking about, and more ideas, suggestions are welcome. This is all, this is a very open exercise, and we're very keen to hear from other people and to share and promote learning in this area. And I think we've been quite successful, I'd say, in raising public and policy awareness of the impact of COVID. So part of the media picked up on this, and it's been very good. I think hopefully we're raising awareness that large numbers of deaths in care homes are not inevitable, and also of the long-standing problems with the long-term care sector. And I have to say, from my point of view, it's an amazing collaboration, and I thank everybody who has come on board and who has maybe turned some of the angst around this into something constructive. So thank you very much. That's all from me. Just to mention that we are planning to have a seminar at the same time every Monday. The next one will be Eric Fuster, who has developed some really good resources with other people in terms of learning from Ebola and other diseases in terms of how we could use risk zoning in care homes, and he'll be presenting on next Monday. We have a few more slots. Some of the new international reports that are coming perhaps could be introduced on next Monday as well. But if you have an idea of the presentation you'd like to give, please let me know. And on the 1st of May, I can also announce that Hong Soo Kim will be presenting on the situation in South Korea. So thank you very much. And I think now I finished sharing my screen. I can't remember who was first, but whoever, so it was Li Fei. Thank you very much. So I hand over to you. Thank you.
So good evening from Australia. As a bit of context for you, we have been socially isolating as everyone has, but Australia's done well in flattening curves. So my paper, I guess, is on our experiences as visitors have started going back into care homes here. We've had 7,000 COVID cases and 99 deaths in all of Australia in terms of context. So once COVID-19 enters a care home, it's difficult to prevent its spread and mortality is high. So our Canadian colleagues on the LTC COVID site estimated a case fatality of between 26 to 29%. And because of this, realization very early, this article from the New York Times basically pointing out that nursing homes should shut down because of such a high mortality rate. Industry leaders suggesting a strict lockdown. And many governments actually have instituted lockdown, meaning banning essential visitors. Here in Australia, they didn't actually do that. They just restricted visitors. And here's a lovely picture of some care staff who locked themselves in, so they didn't go home. They just lived there with their residents with dementia. So it's really serious, and that was great. That's a really important rationale for restricting access to care homes. Again, from the LTC site, we know that even though there's lockdowns in many countries, either instituted by governments or, as happened in Australia, lots of our facilities put in additional lockdowns, that the rates of deaths among nursing home residents is very high, and a very large proportion of the deaths, up to 60% of the deaths in our countries are in care home residents. So I'm not going to cover this today, but I refer you to the examples of things that can be done above lockdowns in terms of reducing the risks of outbreaks and managing outbreaks. What I do want to talk about a bit is the unintended consequences of lockdowns for residents. Perhaps when we have closed nursing homes for the safety of residents, we didn't mean for them to be more lonely, but nursing home residents or care home residents are already very lonely. We know that they tend to be bored or have spent a lot of time doing nothing, and this is worse now. We're hearing reports, anecdotal, we haven't got data yet, on loss of physical and cognitive function. There's less activities, there's less visitors, there's no outings, there's high likelihood of people deconditioning both mentally and physically. Certainly some of those anecdotal publications that have come out suggest that there's an increase in behavior suggesting unmet needs, particularly in residents with dementia. And I would then hypothesize that, these need to be managed in some way, so there might be an increase in physical and chemical restraint. And the impact isn't just on residents. Staff were saying early on that there's not enough PPE, we don't understand, we're really worried about taking COVID home to our families. And where there have been outbreaks of COVID, staff have refused to work, at least here in Australia and other countries, according to the newspaper reports as well. And even when there aren't outbreaks, staff are telling us that there's lots more work to do. The visitors who used to come and feed and spend time with residents, the volunteers, the school kids, the community, the bus trip programs, they're not happening anymore. So staff actually need to do more to maintain the spatial distancing and to support residents. And this is all very worrying and stressful. So here in Australia, we've started having this debate about letting visitors into homes again. So like in the UK, originally the conversation was around banning visitors to protect older people. And a survey of the Australian public, were very kind of supportive of the idea of, restricting visitors to care homes. So there were other opinions. Firstly, that the blanket visitor bans are an overreach because it's got negative consequences for residents, but also that it could be a breach of human rights. Are we allowed to just lock people in care homes because they're old and frail, without asking them? There were concerns about what was happening in the care homes. We're having a Royal Commission into Aged Care here, suggesting that our care homes are neglectful, and there were really strong concerns about care homes not looking after residents properly if there wasn't family going in to see what was going on and no one was monitoring what was happening. Our Prime Minister, once our COVID numbers, once her diet started to warn care homes that they had to let visitors in, or that they'd start to seriously step in, and the aged care sector were basically defending the lockdowns. They were saying, we're doing this for the right reasons to protect our residents. But after a while, by Mother's Day weekend, just a few weekends ago here, most facilities have started allowing visitors, restricted numbers of visitors. And really interesting, I guess, a big consortium of advocacy groups and aged care organisations wrote an industry code for visiting during during COVID, which has been endorsed, so it's been emailed out by our Department of Health here, which is, to me, an endorsement, basically. I had several emails from the Department of Health promoting this document. And I guess it's because there has been confusion and they wanted some the consistent way of managing visitors. What's interesting here is that it suggests some flexibility in visitors. So more visits for people who are at end of life, more visits for people who have that person regularly visit, especially if they were involved in feeding or other aspects of personal care, and perhaps longer or more visits if someone's traveled very far to come and see them. So I don't know the answer of when it's safe to visit. I don't think anyone knows the answer of when we should start allowing visitors back in. What I've been thinking about is that governments are using the basic reproduction number to guide lifting community restrictions. So that's how our government is basically reporting, and many governments around the world are making decisions about how we ease community social distancing. But the reproduction number is not related to prevalence. So reproduction number in the UK is below 1 at the moment, and it's below 1, just below 1 in Australia. But the community prevalence of COVID is quite different. So this is my state's prevalence by region, and our hotspots, which are shown in green, there's like 30 cases. Where I live, there's been no active cases in the last week. So my thinking is that really we should be not just looking at the R number, which is useful, but also at community prevalence of active cases of COVID, which gives us an idea. We can do some guessing of how many asymptomatic cases that might be out there and take that into consideration when we think about safe visiting. And if we are to have safe visiting, then we can put some safeguards into it. So we can limit the number of visitors and visits, like hospitals do. we should be screening visitors in as rigorous a way as we can, the same way that we should be screening staff. And we should be having infection control during the visits as well. So wearing masks, shoe protection, outdoor areas, minimizing time, spatial distancing, good hand washing. And I want to emphasize that just because we have some visitors, it doesn't mean that we've kind of, you know, dealt with the unwanted consequences of you know, restrictions in facilities. We wrote an opinion piece about things you could do, including technology, and we have seen some really nice examples of families doing window visits. So, you know, facilities complain that it's not safe and not hygienic and it's dangerous and landscaping, but, you know, facilities are doing proper organized window visits. So this lady's visits has the dog there visiting her mom, and she's been going every day. This Dutch facility built this cabin where they can do inside but glass visits, which I thought was lovely. So I think we're starting to see some innovative work. I've been working with a group of, I guess, engagement specialists. They're all artists, called the Outside In Collective. We've been doing window, well, it's not family visits, they're like entertainers, you know, or visits, but to have fun and sing and dance. So we play, and we're going into 8-10 facilities at the moment, and we hope to pick up more. So, and we've been doing Zoom visits as well. So here's Annie doing Zoom visits. We've learned how to use technology to do this quite successfully. And I say, think about that. I think, well, what resources, you know, would we need, and what would really help? The stacks of money. It feels like facilities are being asked to do so much more, and there's no more money to do it. So I don't know how to solve this problem. I don't know who's going to fund this, but it feels like if we do want residents to live well during spatial distancing, then someone's got to support that somehow. And there's a bunch of questions that we don't know, but I've gone over time, but still so much more to think about, basically, because it's just allowing residents in. There's still so much before it becomes a normal kind of, you know, care home life again. So thank you. Thank you for the opportunity.
Thank you, Li Fei. And just to say, I don't know, we're going to have another extra half hour at the end for some more discussion, but I know for you it's extremely late at night. So I may allow, maybe just if somebody's got one very burning question for Li Fei, because in Australia, I think it's like almost 11:30 p.m. So yeah, if anybody's got one very burning question, just be quick though. Anyone? No? Okay, we've also got some comments in the chat, which we can also maybe come back to, and I can also send you anything, Li Fei, if you want to go off quietly at some point. Thank you very much. And next we've got Courtney van Hoven from the US. Thank you, Courtney. And we're not hearing you yet.
Okay, I haven't said anything
we are,
yet.
yes.
But,
okay, thank you.
Is that showing it as slideshow?
Not yet at slideshow. So I think you need to press to have it as a slideshow at the bottom. Yes, where you're going, yeah. Not yet. Yes.
Does that show it? How about that?
Yeah, it's working.
It's showing presenter view, not slideshow view.
Okay, I'm sorry. I'm hitting presentation, but it's not going. Oh.
But I think we can see. So maybe just go ahead.
This happened in the previous seminar I was in, and they had to get out of it, get out of screen sharing, and then come back in somehow.
Oh, my technical abilities, I apologize.
We can see. That's
Yeah.
fine.
I think you could go ahead. Yeah.
Okay, well, I'll try to, you'll see all my notes too. So hi everyone. First, I just want to thank Adelina and all of the international contributors to this spontaneous collaboration, because on behalf of all of us in the US, it's been very comforting to know your strategies and just have solidarity, because we all feel like we're screaming into the abyss. So thank you very much for this opportunity. I want to acknowledge my co-authors on this country report, Nathan Boucher at Duke University and Walter Dawson at Oregon Health Sciences University and UCSF in San Francisco. We're going to really talk about a few of the features of our US country report that we put together a few weeks ago. And I'll just go over a quick outline. We're going to talk about the current situation in the US long-term care system. In the US, we have the largest number of cases in the world, which is not something to be aspire to, but also we're a very huge country, 331 million people. As we'll talk about, adequate testing and reporting for the virus remain real concerns. So a lot of the data that I'll present are very preliminary and we think all underreported. The US is also quite an older population. 16% of Americans are over age 65. And over half of those over 65 live with 2 or more chronic conditions. So given advanced risk of death and the complications associated with advanced age, COVID's really had an immense impact on long-term care in the US. We're going to talk about the short and long-term policy reforms needed in LTC, and some of the strategies that Adelina put up really highlighted what we also think we should be doing. So thinking about financing and structure, but we won't go into that today in the interest of time. This map shows current confirmed cases as of last Friday, 1.4 million confirmed cases in the US, and you can see by the different grades of blue there that there's a lot of variation. There were 85.8 thousand deaths confirmed as of last Friday, and 1/3 of those deaths are in long-term care facilities. So very similar to Li Fei's rates that she suggested. That said, we know that there's a lot of underreporting going on. Only half of states are reporting deaths, and those facilities that are certified by the government are those that are reporting at this point. So we know that those numbers will change a lot. So the other thing to point out is that some of the professional societies have been thinking about predictions, and they also have said we should expect over the coming years that there will be up to 30% of residents who die due to COVID. And as some of the things that Li Fei mentioned about how it's so difficult to control once it is in a care home. Some of the challenges in the response that in the US long-term care system have probably very familiar to some of you all, and that is that we have lots of evidence of inadequate personal protective equipment in care homes, a lack of transparency with reporting. In addition, there's a very litigious environment surrounding the long-term care sector. There have been both owners of care homes asking governors for immunity against law cases against them, as well as families, residents urging and trying to use the law to understand what's happening in the care homes and what is going on with their family members. Most states still have no visitor policies, so that is a very real state of the situation, in addition to some of the emotional effects that we don't even have a handle on that Li Fei mentioned. There's also a huge lack of ability to share information between the carers and the family members and the care team. So it's really hard to deliver person-centered care and represent patient preferences without the presence of those carers. Of course, we know why it's being done, to try to mitigate transmission risk. We're going to focus on care homes today, but we know even less about what's happening in terms of protective equipment and things for home health agency providers and also unpaid carers. So some of the contributing factors of the lack of response and failed response, in our view, in the US has been that the long-term care system is very fractured. There's a mix of public and private funding, but generally people are not covered in terms of their insurance for long-term care services. A lot of people are paying out of pocket, and long-term care was left out of healthcare reform that really did extend insurance for receiving healthcare in the US. There's also an overlap of state and federal government regulations that make it very confusing who is responsible to deem that tests need to be rolled out, and yet there's no funding to do them at the federal government's providing. The federal policy response has been very limited to acute care in general, so really focusing on the ICU care and when people have to enter the hospital. So we have called this in our report a major public health failure. There's a lack of who's leading the charge. Local and state governments seem to really working hard. Professional societies and all, however, are under-resourced. The part of the fragmentation in the US long-term care system is really the fact that ownership between the healthcare sectors and the long-term care sectors are different owners. And so there's problems with information exchange and also incentives and taking a long view of the continuum of care. So those are some of the contributing factors in the background. This graph may be familiar to some of you if you read the New York Times, but it just shows that we're really dealing with incomplete information, as I mentioned. So the slightly darker gray shaded states show the states that are not providing any facility data. So some of the information has been able to be garnered from journalistic efforts, but there's not a lot of reporting. So we really know that there's going to be under counts in the data. The White House has announced that they want every nursing home to test within 2 weeks. So that's 1 million residents in certified facilities in the next week or so. And multiple states have announced that they will increase testing. But there's not a lot of resources behind this, and there's not a lot of requirements that tests occur to people who are not symptomatic. So that seems to be a problem as well. There is movement. The U.S. Centers for Medicare and Medicaid Services are proposing that all nursing homes report to the CDC the infections and deaths in the weeks ahead. So even as I mentioned, even as reports are going to be increasing, this leaves out an entire sector that is very important in the U.S., which is the increase in assisted living facilities, independent living facilities, and memory care homes, which are not regulated by the government and that we don't know really how to handle. We don't have a handle on what's going on in those. I want to go back to the topic of long-term care workers in the time of COVID-19, because in the US we have a very unique, I think, in some senses, workforce. That is that similar to other European countries in the facility care, there's about 1/3 of workers, direct care workers, who are immigrants born outside of the US. They also tend to be 93% female and more very high prevalence of women of color. I should have mentioned this at the very beginning, but I think it's very important to point out that the deaths and infection rates in the US have been highly among people of color, so very high risk because of comorbidities, structural, systemic issues of discrimination and racism. And so this is really a huge issue in the US about who is being affected most. This translates to the long-term care workforce in that because of some of the demographics of the workers. But importantly, this is a study that we just recently published in the Journal of the American Geriatric Society, a brief report in which we looked at data from 30 nursing homes in the northeastern US. And what we found is that the direct care workers tend to work on average full-time at this one facility. But as well, 1/6 of them had a second job where they worked up to 20 hours a week. In addition, 70% of the workers agreed or strongly agreed that when you are sick, you feel obligated to come into work. There's very few of them had paid sick leave, and this is true nationally as well. The thing that I think people don't think of as much is that 60% of them were double or triple duty caregiving in and outside of their own home. So just looking at the right-hand figure for a moment, where the long-term care worker is at the center, there are at least 4 places that they're visiting with regularity, or a lot of them are visiting with regularity. The actual facility that they work in, their second and third job locations, their homes where they have the in-home unpaid care recipients. Those could be children or older adult care recipients, and then out-of-home unpaid caregiving. So they're really a high-risk group, both for themselves, the residents, if we don't test them and protect them, and family members and other persons they visit. And again, I just want to make clear that these workers don't have sick leave, paid sick leave, so it's very difficult for them to comply and protect themselves without financial cost to them and their families. This is we go into more detail on this in the report, but in the interest of time, just want to touch on some of the immediate structural reforms that we recommend that are needed to respond to the COVID-19 pandemic and long-term care in the US. These could be at 3 different levels: facility policies, state and federal policies, and family strategies. At the facility level, systematic and repeated testing of staff and residents could be increased, and that could be very helpful. Screening, we think, is another strategy, but with so much asymptomatic pre-shift screening before you get to work and going through symptoms could also be used, but probably less likely to be effective compared to testing. Really working on this protective equipment for the workers, increasing case reporting and transparency, and immediately garnering sick and leave benefits. There's a really exciting paper that came out just today about paid sick leave really does reduce transmission risk. State and federal policies, Medicaid reimbursement is very low and could be increased immediately to support temporary hazard pay. There's worried that staffing will be too low at different facilities, and there's no backup workforce in long-term care like there is in the acute care sector. CMS, which is Center for Medicare and Medicaid Services, has expanded telehealth in light of the pandemic, and really understanding and using that in order to support the care in the care homes could be very useful. And then monitoring and intervening to avoid industry financial collapse. There's real concern that the industry will collapse and that the care recipients will really suffer. In terms of family strategies, trying to temporarily shift for those long-term care workers the unpaid care that goes on in their home to another non-essential employee who could stay at home more easily would be a strategy, as well as paying family caregivers in order to remain safely in their own homes if they have to miss work to do that caregiving. Finally,
sorry, Courtney, about a minute or 2 at most.
Okay.
Thank you.
Yeah. This just shows how we think that we could work on transforming the long-term care system through research. And I think I'll stop in the interest of time, and maybe we can discuss it later, but really starting to test models of care and increasing our partnerships at every level in the health systems, departments of public health, and academic institutions, and at different levels of government to really make progress. So thank you very much. Sorry for the really bad slides and being able to see my notes, but I hope that this was interesting, and happy to take questions later when it's appropriate.
Thank you. And we will be, if the authors are happy, we will be sharing the slides. So don't worry, people will be able to, if you're happy to share them, people will be, we can put them on the website. So anybody, as long as you're happy, and if you want to make any changes, you can send a clean version. And that goes for all the speakers, by the way. Thank you very much, Courtney. That was fantastic. And I'm sorry to rush you, but we will have some time for discussion and questions later if you can stay. So thank you very much. The next speaker will be Claire Goodman. Hi, Claire.
Otherwise known as RPCQCG, unhelpfully, sorry. Right, okay. Oh, didn't mean to share that. Sorry. This is the one I want to share. Okay, right. There. Okay, so thank you very much. This presentation is about some work in progress and is really a reflection on how we respond to how long-term care providers define and identify the questions that they encounter, rather than receiving information from policymakers and the national organizations. So the history to this is that when it became apparent what was happening in England, and there was a great flurry of activity, there was remarkably little information for care homes, even though we had ahead of us what was happening in Italy and Spain. And so a group of care home staff and managers, a geriatrician who they had worked with, a researcher and some commissioners, initiated a WhatsApp group to field questions from the sector, and that had phenomenal pickup very quickly. They were fielding questions and answers at the rate of about 30 an hour, So as you then begin to see, with 256 participants, that wasn't sustainable as a WhatsApp group. So they then migrated that into an app, which is being developed and refined as we speak, but is still a forum for conversation and discussion. And that's now a bit like this group has gone international and has over 500 members. So the distinctive feature of this is that the questions are coming from the sector, and that is then triggering a response from researchers to say, okay, what kind of resources do we need to look at? So it's not negating national guidance, which is now overwhelming for the care home sector here, because they have hurtled to the top of the agenda for many of the reasons that Adelina highlighted at the beginning. And they're now perversely overwhelmed with information which is not necessarily tailored for their consumption, but which is very sound. And there are 7 linked projects, some of which are funded. This one I'm presenting is essentially a coalition of 10 researchers whose organization is enabling them to do this, but we have no external funding for it. So here are some examples from the very early questions from the WhatsApp group, which was circulated to a group of care home researchers in a network organized through something called Applied Research Collaborations. And apart from personal protective equipment, which dominated the questions, and this is about sourcing them and what do you need to do, which is not really a research question, it's a systems question as much as anything else. These were the kind of questions that were coming up. What do you do if you can't isolate people, if they walk with purpose or are wandering? How can you do that? When is restraint ethically defensible? And if it is, whatever can be, what type? What do I do about people coming in and out? All very familiar to everybody. What do I do if we are anticipating decline? How do I get organized and get everything I need for these patients? How do I support relatives and family remotely, and family who are grieving? And when is it okay to hug a resident? And what became very clear is that how care staff work is heavily reliant on physical contact, reassurance, communal activities, all of which were compromised obviously by what was happening. So what I'm going to now tell you about is about how we tackled it. So as I said, we were a group of about 10 researchers. All of us have done work either around dementia care or with care homes. So this was the expertise we were bringing. So we looked at these questions and identified, well, maybe where we could possibly make a difference. And if you look at the left screen, it's almost this is the story of the journey. We went from saying, oh yes, we could do rapid reviews, to realizing the quality of the implementable evidence was possibly not going to be of much help, to therefore going to heuristics, rules of thumb. And we started calling these top tips to help you think. And then we felt, well, maybe that's a little bit patronizing, so we reworded it as top tips in tricky times. And these areas broadly summarize the 8 top tips that we've developed so far, and which capture, I think, what a lot of the questions in the WhatsApp group were raising. So we shared, so if you look to the right of the screen, we shared these questions amongst us and thought, okay, what have we got that could begin to do answer some of these questions that would be research based. We're not trying to synthesize professional evidence, experiential evidence, or we're not trying to replicate what is coming from specialists like palliative care and so on, which is drawing on a whole wealth of experience. We're trying to focus on saying, yes, we can point you to the research that shows this would be a reasonable thing to do. So we did rapid reviews for some topics, and for some topics we took our own programs of research and then developed top tips. We circulated the drafts of those tips, and of course they were full of researcher language. Well, maybe, and you would have to consider, and arguably. And then we shared it with our implementation leads in the Applied Research Collaboration, who were pretty robust in saying that this wasn't going to work, and that we really needed to distill it down and have all that background information about our references and how we did the searches somewhere else. And then the other thing was that we would also make sure that we achieved a reading, we aim for a reading level of 10. I'm going to show you some examples and we can debate whether we've achieved that. Then what we're currently doing at the moment is we're sending this out to frontline staff for feedback. Do you think this is useful? Would you use it? What wouldn't you do? And I have to stress, this is staff involved in care. We're not sending it to the directors of quality, we're not sending it to even necessarily care home managers, we're asking staff. And so it's quite hard to get this feedback, as you might imagine, but through our contacts and through the app resource, that's what we're doing. And it's beginning to trickle back, and it's broadly positive, although staff keep wanting to add their experiential knowledge to our tips, which again is quite interesting. And then the final-ish stage is that we then work with some graphics designers to make sure they are usable visually and work in different formats, app, hard copy, and then we carry on and track their use, see what works, how they use them, and who they use them. So I mentioned that there is an issue about how implementable the evidence actually is. So I'm going to give you 3 examples of evidence where we could, if you like, be very confident this is reasonable, evidence that was a little bit more specific, and then evidence that was very specific. So this one on your left is really drawing on a lot of research literature about how, I have to say, hospital staff more than care home staff communicate with relatives. So like evidence from intensive care about how you talk to families at a distance. And these were the principles that we only came up with 5. I foolishly suggested we ought to have 10 to keep the T's going, and that just created a burden nobody wanted. And I think it's just interesting that, you know, the first thing is acknowledge families' feelings, anxieties and stress, and just helping people think through as a heuristic, what do I need to do when I get on the phone, and so on. And again, drawing on evidence. The one on the right is looking, okay, you can't give somebody a hug. How could you, what do we know about music therapy for people living with dementia? And this, the researchers who did on this have done a review around non-pharmacological interventions, particularly in creating comfort for people with advanced dementia, looking at particular interventions. And these were the, so if you like, the thematic issues that the research identified as important and then was applied, and raising the very basic issue of make sure that the person has a hearing aid. It's remarkable how much research has shown that in music interventions that isn't checked. So those were the ones of taking reasonable principles forward. These are ones that are getting a bit more specific. So doll therapy for people with dementia, particularly in Australia actually, has had quite a lot of, well, reasonable amount of research. But then how do you make it useful? And I was, so one of the very specific things was have open eyes so that it doesn't look like it might be dead, the doll that you're using, to some, and be aware that a resident, if they take to the doll and are looking after it, they might become tired because they might feel they're responsible, and then other issues. So these are getting more specific. And then this one on the right, you won't be surprised, is based on my work because it's way too wordy as it is. And this is essentially research around what, for the small percentage of care home residents with dementia whose dying trajectory is unpredictable. So there's a lot of research that if you do certain things, you can deliver very good end-of-life care. But we found in a series of studies, there was always this small group who didn't quite fit. And it's for this group. And I think with coronavirus, it does trigger a lot of uncertainty. And the big messages here was, do not think you can do this alone. So we were actually saying the evidence shows you cannot be expected to do this. So to provide leverage that you should be able to demand healthcare, clinician, specialist input, you should not be expected to do this. The evidence is strong on that. And then the other area around, well, organize what you're uncertain about. Is it you're uncertain about symptoms? Is it you're uncertain about the multiple opinions about what might be best and who should take the lead? Or is it that you're uncertain whether you can cope in supporting this resident? So organize your thinking. And then finally, I think this is the most specific one, and there are other tips, but I just wanted to highlight this one. And this one is for people who don't understand social distancing or social self-isolation. One of the researchers looked at restraint literature, and I suppose the big message from restraint literature is don't do it, which we would all accept, but was not terrifically helpful on, well, what else should you do if you are trying to do it in that moment, as opposed to the very good programs for non-pharmacological interventions. So this draws on some research done in Nottingham, where speech and language therapists actually looked at how people talk to people with dementia and found that certain phrasing and structure actually got better results and reduced resident distress. And so we've actually offered very specific phrases for staff to think about using. So I think that's the most specific we've got. We've also got one on dealing with multiple deaths, and some very helpful, I think, statements of recognizing when actually what happens when you get compassion, when people are fatigued and begin to lose, actually lose the ability to respond compassionately because they're dealing with the cumulative impact of dying. So in summary, is that all right? This summary?
Yeah, perfect.
So basically what I'm saying is this is collaborative. We changed the research focus from what ought to be done to how it can best be done. It's work in progress. We are open that staff may say, that's no use to us. These are live documents, so they would constantly be changed, never a substitute for other sources of guidance. And we found very little care home specific implementation ready work, which is a bit of an indictment for us. I do wonder whether it, as well as helping people think, it might reassure staff that there is no magic solution out there they don't know about. And it might also be a useful resource when you haven't got time to explain to junior or inexperienced staff. And I really must acknowledge all the people here who are involved in this work, and there are wider projects. And I must stress that this is my opinion and not that of the National Institute of Health Research. And that's it. Thank you very much.
Just a quick follow-up question from me is in terms of making these available to other countries, to other, would there be a good way to do that? Because I expect there'd be a lot of interest.
Yes, I mean, I think we would, that's where the feedback loop becomes so important. But I have to stress, please don't distribute those top tips, because they are researchers suggesting, trying to respond to the questions. And until we know that actually care home staff want them. I mean, the feedback is positive, but I mean, if you offer something to people, people are very polite, and we do need to really push that this isn't so obvious as to be useless in some areas. Thank you.
Thank you very much. And next we have Peter Lloyd Sherlock. Peter, you better if I run your slides or yourself?
I'm going to, would you mind doing them for me?
Yeah, no problem.
Is that okay?
Yeah.
Hi, yeah, my name's Peter Lloyd Sherlock, and thank you, Adelina. I'm involved in a network which is focusing on older people and coronavirus in developing countries and low middle income countries, which is, again, established very spontaneously, is growing very quickly and operates in a very similar way to LTC COVID. We have weekly webinars, blogs, various other activities, and I've just put the website there if you're interested. Next slide, please. So, of course, population aging is not as pronounced in Latin America as a region compared to high-income countries in terms of the percentages of the population at older ages. But when you look at the absolute numbers of older people, clearly those numbers are very large. So we can see here that there are about 38 million people aged 70 or more across Latin America and the Caribbean. Equally, the view was, and still is among some people, that the difference in culture and social context in Latin America and the role of women, etc., means that care homes are far less common, and that the vast majority of long-term care, even more so than in other parts of the world, is provided in the community and by families. That was never really true, and it's certainly becoming much less true very quickly. This is a very fast-growing sector in all parts of Latin America. There are some luxury, high-quality providers for the very wealthy Latin Americans, the lucky few, but most care homes in the region are very stretched in terms of resources, very basic, and not at all regulated, or if they are regulated, only in theory and not really in practice. Next slide, please. Oh, previous one, please. Oops. So, oh no, you get the wrong way. So go back to, please. Anyway, I'll just talk to the slide. Yeah, so if you try and obtain information from different countries in Latin America, we're on the wrong side, that's it, the one with the iceberg. They will tell you that in most countries there are several thousand officially registered care homes, nursing homes of different kinds. And that may seem a large number, but in fact this is just the tip of the iceberg. In most countries in Latin America and the Caribbean, people estimate that there are a similar number of care homes that are entirely unregistered, they're not on any official lists, and therefore are invisible to public agencies. And also there are large numbers of what we might want to call de facto care homes. So these are establishments, collective living arrangements like worker hostels, which have permanent populations, which have aged over time. They don't see themselves as care homes, so clearly they are for the purposes of this pandemic. And that is it's not an exceptional living arrangement in many parts of Latin America. Now, I don't want to essentialize, next slide please, about Latin America or care homes in Latin America or overly generalize about them. But I do feel that the sector in Latin America does have some key features that may not be entirely unique, but I think are especially prominent in this part of the world. And so firstly, a very high proportion of residents in many care homes have little or no care dependency. And I think that's important in terms of the sorts of strategies and interventions that we may want to consider for coronavirus. Of course, we've heard about limited resources in places like Australia, but here we're talking about very, very scarce resources. Most residents sharing rooms, often with very large numbers of older people. That is very much the norm and not the exception. Very few trained staff. Very little understanding about issues of dignity and human rights, at least formal understanding about these issues among staff and owners of care homes. And even for that group of care homes which are on official registers and are supposed to be subject to periodic inspection, information and quality assurance are very weak. Now, of course, you hear that about other parts of the world, but just believe me that it's even worse and even weaker in Latin America than in Europe or North America or Australia. And likewise, government responsibilities at local level, and I'm sure you would talk about problems of coordination between different local government agencies. I would say here, as a generalization, it's not a problem of coordination, it's a complete disconnect between, for example, local departments of health and of social development and social services. So I think this does make, these are some general statements you can make about Latin America, and I think you can also make those about other middle-income countries in other parts of the world, such as South Africa and Thailand, where I've also been engaged doing research and policy engagement. And so with all of those particular features about the region in mind, with some colleagues, I've been from the region, some experts from the region, we've been very, very rapidly throwing together a draft emergency strategy. Clearly, the region is now just starting to be very, very hard hit by the pandemic, especially Brazil, Ecuador, to a certain extent Mexico. Very little attention has been placed on social care facilities in terms of the region and the pandemic. There is a sense of this being the tsunami is about to hit and a real need to move extremely quickly. Next slide, please. So this is what we've thrown together very quickly. So we refer to this as the CIAT strategy, which has a number of steps. Firstly, any strategy must involve a new interagency, interdisciplinary task force with very close, seamless, we would like to think, coordination between local health and social agencies. It has to be a new organization because there's been so much institutional policy failure with existing structures. And it needs strong leadership and support from the highest levels of government, the president, the local mayor's office. It has to be seen in these countries as a national priority. We know that wasn't the case in richer parts of the world, and now they're regretting that. Those lessons are not being learned as I speak in Latin America. So this needs high-level political support. One of the first things this task force will need to do is to develop some meaningful guidance, protocols, perhaps along the lines of the ideas that were being set out by our previous speaker, things that actually make a difference. in these sorts of settings. The guidance that I see being published internationally and even in Latin America is of almost no relevance to 90% of the care homes. It's just going to be used to hit them over the head with saying you're not doing what you're meant to be doing. So that's the coordination part. Then we need to focus on identification. We can't help care homes if we have no engagement with them. We can't help care homes if they don't feel safe to share information and to engage about what's going on inside. So we need to extend this strategy to find unregistered and de facto care homes, probably working very quickly with local civil society organizations, NGOs, making public appeals for information. And this is very controversial politically and why it needs high-level political support. There needs to be some offer of some kind of amnesty for not having fulfilled some of the standards theoretically required of these care homes in the past. I'm not talking about the most egregious forms of elder abuse that might take place in those establishments, but perhaps not having enough smoke detectors. It's important, but in the current context, I think we can turn a blind eye. And this will hopefully encourage care homes to come forward and to engage. Then we have to conduct a universal assessment of all parts of the care home sector in this particular administration for this particular task force. A short, focused, simple online questionnaire survey. We've got examples in different languages that we're already using in South Africa and Argentina and Brazil, which I'll be happy to share. And again, repeatedly, saying that this isn't about prosecution, this is about support and encouraging people to be straight up and honest and frank about the situation in their care homes. I think that's extremely difficult, but we have to try and achieve that. And then having done that, there should be opportunities to apply certain criteria, and I think a lot of those are quite obvious, but that's something we've developed, for care homes that need particular special support from the task force. And this can include a range of emergency measures that I'm already seeing being rolled out in different parts of Latin America. In Chile, one of the things that's been very interesting is that in some of the worst care homes, before there were any infections in those care homes, they started relocating residents with low levels of care dependency or no levels of care dependency to other places outside of the care home, such as buildings owned by churches and religious organizations, providing them with basic care facilities. But this is very helpful because this reduces the risk of infection for those older people before it's too late, because once you start testing one person as positive in a care home, you've had 2 weeks, everybody will have got it. And also it makes more space for remaining residents to be able to manage social distancing and risk of infection. Another intervention I've heard about.
Peter, sorry, just 1 second. We've got about a minute left because we're, yeah.
Okay,
thank you.
Training care workers to target the most vulnerable care homes, and more frequent visits from health professionals to monitor the context of the epidemic in those particular homes. Next slide, please. This is a story from Argentina a few days ago. Care home Buenos Aires, 5 people dead, 19 more cases so far. First case was reported 3 weeks previous to that, and nothing was done to manage it within that care home. So it was known, not just in the care home, but more publicly. They were told just to isolate suspicious cases in a single room that wasn't appropriate. There was no equipment. The care home is now actually being under official investigation and maybe prosecuted for breaching standards and protocols. So how many other care homes are going to cooperate with the authorities when this is going on? So the business as usual model simply can't be allowed to happen. Next, please. Skip, please. Skip, please. Oh, just go back to that one. This is a link, the Blue website, to an initiative I've been working with very closely in an Argentine city called La Plata, which has been very helpful in developing a network with registered and unregistered care homes over the last week, and seems to be showing that it is possible to bring some of these more clandestine care homes within the ambit of interventions. Next, please. This is an example from the Brazilian city of Belo Horizonte, where they carried out a survey along the lines of our strategy. They were only able to include the registered care homes, but they were able to apply various criteria and identify various homes that are at high risk. And now they're doing a number of different things specifically in those care homes. Next, please. And this refers to some of those interventions in those care homes. Next, please. So thank you so much. Sorry for gabbling and overrunning. As I say, do check out the global platform. We are running a webinar about Latin America and older people on Friday. It will be in Spanish. And on the 29th, we have our weekly webinar on elder abuse and coronavirus. Thank you very much.
Thank you very much, Peter. That was, and thanks for rushing through such a rich amount of information and material. And I do encourage you to take part and to go to the Corona Older website, and there's webinars, especially if you're interested in low and middle income countries. But I think even from high income countries at this stage, we can all learn from each other. Definitely. So we now are on to the more discussion part of the webinar. So we'll stay on for the next 25 minutes. And I'm going to be monitoring the chat box. I think that will probably be the best way. And what I'll do, because there's quite a lot of messages already, and it would probably take me too long to go through. If you'd like to speak, just send me a message now, quickly, and I'll be then inviting you to unmute and speak. We will, of course, we have recorded these, and we will be sharing. I will be sharing the slides and make sure that everybody has access to the recording. So a new message. Peter, okay, that's about coordinating, sharing information. Thank you. Any questions?
May I ask a question, Adelina?
Yes, go for it, Peter. Yes.
Okay, well, I've set out the context, and I'm somebody who always works in low and middle income countries. So for people like yourself and other people in the group, trying to imagine the scenarios that, that I described very briefly and generalizing hugely, what do you think are 2 or 3 top tips, to use the parlance, that you think, the meeting we're having on Friday will be about what can be done in the next few days, the next few weeks at most. So it's about very specific practical tips that we can rapidly disseminate to people working in care homes and to local government agencies. So please, I really need to know what you think might work.
Okay, I'm going to first invite Claire, if there's anything that comes from the work you have been doing. Sorry to throw that. And then I will come in as well and invite openly to others as well. Claire, would you mind?
Well, I suppose the learning that we're trying to push from this is to start with the care homes themselves and actually introduce some kind of systematic way of working from the care homes out, because I think our experience has been that they were ignored for a while. I know Liz is on this webinar from the National Care Forum, and then suddenly they went to the top of the agenda, and Adelina was a lone voice. It seems improbable now, but when the website went up, that was the only resource that was talking about it in a way that was discursive. So I mean, I think there are some principles. I wouldn't be able to say how you then share the top tips, but there clearly are recurring things. I mean, all the presentations I think highlighted about PPE, which just needs to be sorted, and you should be able to see that coming. Yeah, if that helps.
Thank you. From me, what I'd say is that making sure homes know what to do. They have that, and they can be realistic about the extent that they can manage these and when to really go out and call for help. So I think it's very easy to say to homes, oh, just isolate people, but what that involves and how to do it properly is a bit more complex. And I think that that's mobilizing tools that show how to prepare and what you can actually do, and when you have to really just say to the hospital, you have to take these people or you have to find somewhere else, be very important. But I appreciate the complexity of the context and all the issues around the structure of this sector and how it can be done. But I'd like to open this up. Maybe Liz Jones, would you like to come in? I also saw you had the question, so maybe you can try to respond and ask your question.
So I think, thank you. Nice to see you all. Fascinating. That's all been really very interesting. So thank you for running the session. I think there's a few observations that we would make from talking to our members across England and Wales. We've got a few in Scotland. So the importance of this being a health pandemic and the real urgency for making sure that good clinical health support is accessible by care homes, particularly those who don't have nursing specialists within them, so are much more residential settings. The withdrawal of support from primary healthcare services at the time that we were at the beginning of this crisis was a fundamental error. And it was associated with a number of assumptions, I think. There was not an assumption around intent to treat older people. There were assumptions that older people would not be able to recover well from this virus if they got it. So I think there were some fundamental problems with the attitude behind the policy making. In terms of practical things, we know that this virus is much harder to manage than the other sorts of infections that and diseases that care homes are used to. So super specialist infection prevention control advice is really important. This is the equivalent of Ebola, not norovirus, and most care settings don't have an Ebola expert, so that support around infection control. Testing, we've been very late to the party. We should be testing consistently, routinely and regularly. Everything we know about asymptomatic transmission has really undermined care providers' ability to manage outbreaks in care settings, because if you're not testing regularly, you can't spot the super spreader. And then access to PPE has been a real challenge. So I think we've learned that combined with testing, the three bits of the jigsaw really are routine testing, access to PPE, and resources to support care providers in implementing the things that they know that they need to put in place, but perhaps they need specialist support on. The question that I had was around the Australian presentation was really interesting, and there was the question about how the R factor, the reproduction factor, relates to community prevalence. And I think that's a really interesting question for us, because here in the UK, we are starting to see some moves, small moves out of lockdown, but with the very clear emphasis that we're still in sustained transmission across the country, and different interpretations of what that looks like, because we've got different levels of testing across the country. So I was really after your reflections on that relationship between the reproductive factor of COVID, infection rates, and the kind of prevalence in communities.
I mean, my understanding of the maths is that there's no reason for them to correlate. I mean, the R factor is a measure of current viral spread, which is independent of community prevalence, which means that like Australia's R is just under 1, but we have very low community prevalence. UK R is under 1, and you've got much higher community prevalence. So if I were to open my care home R, I would be happy to visit my mum in a care home in my area, because there's no known active cases. There are probably some asymptomatic cases. But in London, where my brother is, I wouldn't let him visit my mum in a care home there, probably, because of that community prevalence. So I don't want to dismiss R as not useful in considering it, but R is the number that governments are using to ease social distancing in community, because it's a measure of how fast the spread's going or not. But if we're interested in how much, like what the risk of bringing the COVID into a care home, then we have to, in my head anyway, you have to consider community prevalence as well, regional prevalence. Yeah. I don't know what the number is. There's no science to that.
And I think the part of the challenge is we've got one R number being used really, but we know there are multiple R numbers in different areas, don't we? And we also know that testing is variable. So that picture of both infection rate and prevalence it might be better in some areas than others. It's interesting. It's simply that there's a narrative emerging that actually part of the problem is infection via care workers because they're moving between care settings. And we saw those interesting stats from the States, and clearly, you know, that may well be the case there. I'm just a little bit concerned about a narrative that starts to blame care homes and care workers for this when actually it's a much bigger system problem. So yeah, so that's interesting. Thank you.
I can jump in. We've seen that in countries like in Australia, where we've had where the virus has been contained very quickly in the whole country, at community level. Then we've had much lower rate of infection, because whatever care home workers do, they'll still be going in and out. They'll have to go shopping. We'll have to do all sorts of things that they can't necessarily. That means that unless the rest of the community also doesn't have the virus, it's very likely that they will get in. And I think that local level information and good links with local public health are essential to help care homes, I think, be able to prepare their response. I'm going to invite Fiona Marshall next. I think you had a question. Or a comment? Are you still there? No? In that case, I'm going to ask, I don't know if I pronounce this well, but it's Mao Pin Tan. Hello?
Sorry, I couldn't find my mute button. Hi, I'm Mo Pin, I'm from Malaysia. We share a lot of commonalities with the Latin American countries in terms of unregistered care homes. I was quite surprised at how Peter felt it was very difficult to reach unregistered care homes, because as a healthcare professional, a care home is a care home, and many of my patients go to unregistered care homes, but I don't know that they're unregistered. So how have you been trying to reach these homes? If you go through if the only ways to reach them is through registries, then that will limit your ability to get to them. Is there another way that you can actually reach them, you know, through mass media communications or social media?
Thank you. Yeah, I mean, unregistered means that nobody even knows these homes exist. No official agency at all is even aware of their existence. So it'd just be like me opening a few of my spare rooms and bringing in a few older people and charging a bit of money, and probably having no engagement with health professionals. You know, it's as informal and as basic as that in many cases. Or in some cases, perhaps slightly better run care homes being run by clinicians who certainly don't invite and don't encourage any kind of oversight about what actually goes on inside those care homes, because they are painfully aware that the standards of the care they provide leave a lot to be desired. So without wanting to sound too cynical, you get the glossy brochure, the only time with the doctor's face on the front. The only time the family ever sees the health professional is when they have the first interview when the older person's being considered for admission into the care home, and they take the money and run to the bank. That sounds very hard-nosed and cynical, but that is really what you see going on in a lot of these places. But even the registered care homes we find very hard to reach. For example, a couple of years ago, I was in the main regulator for care homes in the province of Buenos Aires. The province of Buenos Aires is not that much smaller than England, and they had one member of staff. She was told, because of concerns about public sector corruption, she had to go into her office every day, so she had no travel budget. And the only way she could figure out what was going on in care homes hundreds of miles away was simply to ring them up and ask if everything was okay, which she occasionally did, but said, basically, I'm wasting my time because they just tell me anything. Now, those were the registered, regulated care homes. That is the context we're working in here. So it's very, very hard. It's a very murky business. And often institutions which are meant to be regulating care homes find it not in their interests to take a very robust approach to that, and frankly often are rather corrupt. Don't quote me on any of that, but that's the situation we're dealing with.
We're recording it.
Oh,
But,
no.
Yeah, but I mean, I can ask. So let me just move so we make sure we can have as many questions as possible. Richard Humphreys, I think you had a question or a comment.
Can you hear me?
Yes.
Great. Yes, it's this sort of $64 question really about testing, which has been a nightmare in England for a whole variety of reasons, and not just in care home settings. I was just wondering if there were colleagues from other countries that could give us some top tips on that one and how they've managed to do better than we have, which is probably not a very high bar.
Just wondering here if there's anybody from any country where they think they've done it well that would like to come back. I mean, my understanding is that in some of the Asian countries, they were able to upscale testing very quickly. So was the case in Germany. And I think that is a very structural issue of how this has been organized at the government level. And then there's, of course, the issue of how do you prioritize and how do you make sure that it reaches care homes and people in these settings. I'm just waiting in case anybody wants to jump in and give us an example from their country. Not yet, I can't see anything. No. So we'll leave that as a question that hopefully somebody will volunteer to write a report on to give us an example. Oh, there's Courtney. Hi, Courtney.
Adelina, I don't have a solution because we haven't enacted it, but we've been thinking a lot about how you prioritize testing in light of scarce resources. And thinking about, at first I was thinking it's the quality markers could be a way to target rolling out of testing, but that really hasn't borne out. It's really about trying to, my idea is that it's really about going to the hotspot areas and trying to prioritize there because it's such a community spread that happens in the nursing home. But we certainly haven't achieved that yet. But thinking about ways when there are scarce resources, how do you target things in a rolled out way is a good idea, but I don't know the answer of which should be best.
From my point of view, I think a link with the level of community spread around the care home. So a good combination of what we know from intelligence from the local area and the care homes would be probably the way we'd want to go. And that means that we need to have very strong links with local public health. There's somebody called F. Lin. I'm not quite sure how to pronounce. Is it Flynn or is it a different name? But he had some questions in the comments, I think. You know who I mean, but somebody knows. It's on the chat, F-L-Y-N-N. Scott, I can't identify you from the face, sorry. No, so in that case, I think there was a comment from Eric, and in fact, Eric is going to be presenting next week. So feel free to also trail your presentation as you make your comments and questions.
Sorry, come again.
So Eric was saying you had some comments on the chat box, so I'd invite you to make them. And also I'm also saying that you will be presenting next week. So I think people will love to hear what you're thinking of discussing, also in view of what you've heard today.
Yeah, actually, I was just busy trying to copy across another link here in reply to, there we go, to Courtney around the testing thing. I just saw this came out from Public Health Scotland a couple of days ago. Just been reading it through this morning, but it's basically about testing. They finally got around to the idea of the risk of pre-symptomatic and asymptomatic transmission of residents and staff, and therefore testing staff and residents, and how often, and if you've got no cases in a home, do you still test, and so on. So from about page 10 on that link onwards, you might find something interesting, I think. But yeah, regarding the other stuff, earlier on I was muttering about something, wasn't I? Yeah, just in terms of, so testing for me, I don't know, it's interesting, but like I was discussing with a care home manager the other day, and the question would be, well, how often do you test? And at the moment they're testing, and then it's like a lag of, I'm not sure, is it a day or two before the results come in? And then that person you tested, the staff member, they've been probably if they are pre-symptomatic and they had a positive test, they've still been working those 2 days, you know, and shedding the virus. So it's really, I mean, testing is kind of interesting, but the question, I suppose, would you focus on maybe staff, or would you do on residents, or do you, if there's already an outbreak, do you bother testing everybody, or is it more better to sort of, once you just had one case, then you sort of go to those hotspots and test everyone, you know? So there's questions there. I'm not sure I have the answers for those really, but for certain. But what I was saying in the chat box is I'm not sure testing is the answer. Like we were saying, PPE. You know, there's been a focus on PPE, the answer, and all the news is about PPE, or always about testing. But for me, it's all really about these, you know, hands that put the virus in different places. Like I've just done that, and I picked up my pen, and now I put it down, and somebody else picks up the pen. That's it. I mean, it's a very interesting video done by Japanese TV or something, where they looked at fluorescent stuff on hands and 30 minutes of people in a restaurant and how far the virus had spread, or the fluorescent stuff had spread. Just goes everywhere. So really, for me, it's preventing the transmission of, yes, somebody sneezing on you, but really this touching stuff. How do we stop the touching, the contact of things? You know, and of course there you're talking about obsessive hand hygiene. That's why we need this zoning principle, in my view. It's basically making your care home into like an Ebola treatment center, you know.
And Eric, could you just quickly talk just very briefly about your resource, and hopefully you'll be introducing it a bit more tomorrow, next week.
Sorry, I go on and on if nobody interrupts me. So that was the thing before, the bushproof one. That is basically a care home strategy that we've had online for about a month now. So I'll probably talk a bit more about that next week. Maybe we'll update the subject depending on what happens this week. But basically it's based on SARS outbreaks and Ebola outbreaks. How do we then translate what we know about the virus transmission within a care home setting, while trying to think pragmatically about what would work, or what's the next best scenario when you've got an imperfect situation, which most places, they don't have enough staff or PPE or time or anything else, or the physical layout is difficult. So it's like trying to look at a pragmatic way forward, and yet something that's not tinkering around the edges and ticking boxes, something that's actually going to work as well to an extent.
Thank you, Eric. So next I've got a comment from Christine Bishop.
I wondered if anyone has looked at, it's apropos of what Eric just said, whether PPE works, whether variation in access to PPE and knowledge of the staff of how to use it properly, don and doff it and so on, whether variation in those things has affected spread within a home.
That's the kind of evidence we'd like to see coming, but I don't know myself if anybody generating. In terms of a comment, going a step back, so we discussed testing, we discussed isolating, we also discussed PPE, we discussed all other things, but I think one element that's very important, and that's, I think in Germany, the guidance is very well developed, is on contact tracing. So once you have one case or a suspected case in a care home, and I think in South Korea, from my understand, the idea is that as soon as you have a suspected case, whether it's a member of staff or a resident, same in Germany, then you do full contact tracing. Who has been in close contact with these people and to what degree of close contact, and then you develop a strategy around those people. So even if you haven't got their lab result yet, you can already start identifying the people who may be possible cases. And then you start thinking about how to minimize the potential for infection. And I'm hoping at some point we'll also be hearing more details about how they're doing this in Germany as well, and South Korea. I'm going to move to the next question. There was somebody, and I'm sorry about the name, it was Uni Global, sorry.
Hi.
Yeah. Oh, hi. Sorry.
Sorry, my name's Mary Catherine. I'm from Uni Global Union. And my question is directed about how do people think we can link the ability for there to be the availability of long-term, full-time work at care homes. One of the things we hear from our members is that, you know, they have to work at 2 or 3 homes in order to piece together a full-time job. And you know, we'd like to know, how do we advocate either with government or through research about getting, you know, to have these jobs become full-time so they could work at one single home instead of, they're concerned about being vectors of transmission to multiple homes.
Anybody has any comments on this? So to be, it's basically about how to respond policy recommendations.
Pay people more.
That would be my response as well. But how do we address it as together? There's so much going on about PPE, and so it's I think one of the bigger problems is that people don't have access to full-time work, and therefore they're exposed to, they don't have decent pay, they don't have access to PPE, and then they also are putting themselves and the people they care for at risk.
Yeah, and even those who are working full-time at one facility have a second job. So I think if some care homes are requiring that you only work one place now, but they're not increasing pay at that one place, which is a huge financial penalty. So having an increase in wages is either through Medicaid increasing rates or other government intervention is the only way to reduce the financial hardship of having people reduce the number of places they go.
There are a number of countries where pay rates have been increased. In most of them is a one-off payment during the crisis, but there's a few where I think and I'm just saying that from memory now in our international report, there are a few examples of countries that are making the increase more permanent. Now in theory, we're at the end of our time. I'm very happy to stay on for another 5-10 minutes. There's a number of questions I have already, or people have already noted. If you need to leave, please feel free. And thank you very much for taking part. If people are happy to say 5-10 minutes, I will still be here and happy to bring on more questions. So the next one we had was from Maria Aurora Fenech. Hi, Maria Aurora. You want to unmute yourself?
Hi. I didn't put a question really. I just suggested how some of the care homes were currently working here. So it's a kind of a split shift. So they're 3 weeks in the care home, and then they come out and another shift goes in, and they stay within the community with the rest of the family. And then 2 days prior to going back, they get swabbed and then they go back. So there are other homes who have been in lockdown for the past 10 weeks. And then there's the largest institution on the island. They're still not on lockdown. So healthcare workers go in and go, they go on their business as usual. And there's been one of the members of staff there who has tested positive since these 10 weeks. But so far we haven't had any cases within the care homes.
Wow. I've read of a similar strategy in Jordan, and also they have in fact there the staff are living in the house. Is that also what? Yeah, and they haven't had a single case either. But the contact tracing is very different.
Contact tracing over here is rampant. So it started as of day one when we had the first case in 7th March. So contact tracing has been ongoing ever since.
Thank you. And I understand you're going to be providing a report for Malta.
Yes, we've got a meeting tomorrow. Yeah.
Thank you. And it will be fascinating to be able to share this.
Hopefully things will remain they are, because we're starting to ease down measures as of this week. So hopefully things will remain the way they are.
Thank you very much.
Thank you.
Next, Shireen Hussain. Yeah, I can see you. You're still there.
Yeah, hi, can you hear me?
Yes.
Yeah, well, thank you very much. It's really fascinating. And I think I just wanted to put, to make a comment that I think have been already made, but around workforce and how we can get out of the narrative that they are part of the problem, but it's more of a system issue. So truly what we're hearing, and we're hearing from care homes now, that even the permanent staff, when there is a COVID case, a positive case, some of them actually stop working, and then the care homes rely on agency staff and more temporary staff, and it just how to communicate not only with the workers, because I know they need the tips of how to infection control and everything, but with the higher system, not only policy, but I would presume practice, and trying to approach budgets that will will have some guidance to care homes to protect staff and protect people. But I have so many other questions, but one is for Peter as well in terms of the low and middle income countries, as I have a big interest there, and the dilemma working with governments who would try to do their best to ensure that the level of reported cases are as low as possible, and not being cooperative in that matter. So that's maybe another discussion, but I think it just maybe if he can highlight a little bit of these issues, that it's not easy to access information, tests are not, you know, that they're not being done on a systematic or a high kind of numbers or amounts. And also, yes, care homes exist and they do thrive in low and middle income countries, but the interplay between community and care homes is very, very strong as well. Thanks.
Thank you very much, Shireen. Margaret had a comment, but she had to go. Kellyn, are you still there? Or no, I think I haven't been able to get round to everybody, but is there anybody else who wants to have a quick last word before we close for today? And
Adelina,
yeah.
Sorry, it's Peter here. I'd just like
yes?
to respond to
Sure, of course, sorry, yes.
Low middle income countries. I mean, a couple of quick things. Firstly, a real issue, and it may be in other parts of the world as well, is that there's a real concern among people working in many care homes, who are mainly women from deprived urban neighbourhoods who have no other livelihood opportunities, that if they are found to be suspicious symptoms, they will deny having those symptoms because their pay will be stopped immediately. And of course, at the moment, they're dealing with neighbourhoods where rates of infection are very high because they live in shanty towns, and they're in situations where livelihoods are very restricted because of lockdowns. So there has to be some kind of approach to, and these are people who aren't unionised, who don't have any formal protections in terms of the labour market. So there has to be some approach to try and, again, discourage care homes from stopping paying these people, because otherwise the consequences will be disastrous. And in terms of political engagement and governments, you know, not wanting to play down the number of cases in care home, absolutely sure. I'm not really dealing with that at the moment, because what I'm trying to do is build bridges with government agencies so that we can work together well to stave off the tsunami. But I am very, very mindful of the wider political agendas, especially working in a country like Brazil, which is very miserable. We've got the health minister's signature for a large intervention
being recorded,
on Thursday.
Peter.
Oh,
Just reminding you.
We got the health minister's signature for a large intervention with the Inter-American Development Bank on Thursday, and he resigned on Friday, so it didn't count anymore. And then we didn't get we couldn't submit our thing to the Inter-American Development Bank. So that's the political reality.
Thank you. And I think, Kellyn, you had a question. I think I see you back now. Did you want to quickly make that before we close? Yeah, that's you, but you're muted.
Hello, yeah, I mean, it was not necessarily a question, but more of a comment. So my research looked at the objects that people are allowed to have in care homes, so people doing things more independently. And I just wonder whether that might be useful at a time of social distancing in which, you know, you need this space, and actually objects can be something that can enable people to do things, activities, meaningful tasks, which can perhaps help them during these days when there isn't very much going on.
Well, we'd love to hear more about it, Kellyn. So if you see that as an invitation for a blog post for LTC COVID, or maybe a presentation, please feel free to send something. Thank you very much. So I think we should really end now, because we're really over time. And I think for Li Fei, we should really allow her to go to bed before tomorrow, or maybe it's already tomorrow for you. But sorry about that. But thank you very much, all of you. That was fascinating, fantastic. And we're welcoming presentations for next week. So please do send me we have one slot, we've got 3 more. If not, we can fill them up from the LTC core team, but we'd lovely to hear more from more countries and more questions, more issues, suggest topics. Please feel free. We welcome blog posts, we welcome reports. Please email me. My email, I think, is somewhere, is all over, but if not, just send a comment to the CPEC through the invite form. And next webinar, same time next Monday and one the Monday after, and we plan to keep going as long as there's interest and people willing to speak. So thanks again. We plan to share the slides. I will give the speakers an opportunity to send amended slides if they want to. We'll also be sharing the video and we'll make sure that nothing politically controversial is there. And thank you again. I hope you have a good rest of the day or night in some cases. And thanks for joining us. Thank you. Bye.
Thank you.